And so now we are very excited to have Professor Chantal Ski from University of Suffolk to talk to us about the application of AI to health, particularly heart failure, and to bring to life a bit more this amazing innovation of DrMe. Over to you, Chantal.
I know this festival has seen a lot of innovation as an accelerated outcome of COVID-19. However, if we think back to days, life before COVID, our greatest healthcare challenge was, as it is now, finding solutions to an overloaded healthcare system. What the pandemic has done has brought the same challenge into sharper focus. This presentation, putting AI at the centre of heart failure care, a paradigm shift from reactive to proactive care, began its journey 2 years prior to COVID with the aim of developing a virtual heart failure at-home doctor to act as an enabler for predictive, preventive and personalised medicine, or in layman's terms, effective heart failure patient self-care. Since its inception, the core objective remains the same: improving outcomes in patients with heart failure being the most prevalent, complex, and costly form of cardiovascular disease. So I'll begin with a brief description of the partners involved in this project, known as PASSION-HF, an acronym for Patient Self-Care Using eHealth in Chronic Heart Failure. More specifically, an AI-supported avatar offering personalised care 24 hours a day, 7 days a week. This is a 3-year Interreg-funded research program of over €7 million, involving partners from 5 countries: the Netherlands, Ireland, UK, Belgium, and Germany, across technology, clinical, and academic organisations. For example, in technology, Sananet specialises in telemonitoring and eHealth for best remote care. Explorers provides artificial intelligence-based diagnostic and therapeutic lab tests. And Neurogames offers gamification solutions and software engineering. And the academic partners, such as Queen's University Belfast, Maastricht University Medical Centre, and University College Dublin, all linking with local hospitals as our clinical sites, which equates to a multidisciplinary team comprising technical experts, academics, researchers, and clinicians, including cardiologists, nurses, heart failure nurse specialists, and a psychologist. So just to give you a brief rationale on the project. So it goes without saying, AI has game-changing capabilities to revolutionise healthcare. And as heart failure is one of the most burdensome long-term conditions, there is almost an obligation for intervening using AI. What's most worrying in regard to heart failure is it's increasing substantially alongside increases in predisposing diseases and comorbidities such as diabetes, hypertension, and obesity. Also a growing Western lifestyle in developing countries, which I should say, before the Western lifestyle had near negligible cardiovascular disease, along with the well-documented global aging population. Together, and COVID. Together, these pose unsustainable demands on our healthcare systems. We've all seen it. It's been on the news, hospitals overflowing, patients being treated in ambulances, in hospital car parks, and patients moved into hotels. So a new vision of care is mandatory, one that embraces AI and digital technologies to drive fundamental change in heart failure healthcare. The key point here being the paradigm shift. What this has allowed us to do is to move from the currently applied reactive, old school medical model towards a predictive disease care approach. AI is a rapidly evolving field in medicine, especially in cardiology. It's revolutionizing risk prediction and stratification, diagnostics, precision medicine, workflows and efficiency. So being able to pull data sets smartly and extrapolate relevance at an individual level, our AI approach, called DrMe, offers personalised care 24 hours a day, which also presents great potential for reducing clinician burden, improving clinical efficacy, and enhancing patient experience and outcomes. For example, for healthcare providers, AI has the potential to decrease risk of adverse events and per capita costs, whilst increasing accessibility, productivity, and overall patient experience. For clinicians, AI has the capability to reduce workloads and margin of error and improve needs-led doctor-patient interactions and therapeutic decision-making. For patients, AI can empower through increased knowledge, shared decision-making, and self-efficacy in disease management, ultimately improving their health and well-being. So in order to achieve all of these desired healthcare provider, clinician, and patient outcomes, our aim was to define a holistic model for self-care of heart failure, facilitating the conversion of real-life target group needs into a decision-making engine. And in order to achieve the overarching aim, our objectives were broken down into identifying 4 models of heart failure care. The patient model, encompassing user aspects, patient acceptance, and ease of use. Then the medical model, all clinical aspects, and for the first time, advanced medication advice and also prescribing. The holistic outcome model, which had to be an all-encompassing model of biopsychosocial outcomes, which was achieved through a very large systematic review, which actually identified all available heart failure outcomes of randomized trials. And it also had to be a transnational model, crossing the 5 countries, which included things like thinking about the implementation aspects of DrMe. For example, getting access to patient records and data considerations. So in the most simplest of terms, DrMe is a self-learning decision-making support system designed to help those affected by heart failure in their daily management of the disease, as well as in their treatment decisions. So in essence, allowing them to become better self-managers, including involvement in their treatment decisions, and also offering medication management. This diagram represents a typical day with DrMe. In the morning, the doctor welcomes the patient and asks them how they are doing. Once the patient responds and answers a few basic questions about their heart health, the doctor will identify if in any way their health has deteriorated. And if so, the doctor will then adapt their heart failure therapy, for example, their medications. And on that point, it's important to note that the creation of treatment algorithms are based on internationally standardized clinical heart failure guidelines that have been integrated into the DrMe system. So if the patient feels unwell or has any questions at all, day or night, the avatar is always available to offer instant advice on how to manage the situation. In this way, DrMe enables informed health decision-making. So this diagram here is a basic representation of the AI platform used to support DrMe to implement predictive rather than reactive approach to heart failure self-care. As you can see, DrMe uses multi-level diagnostics such as medical imaging, self-organizing maps, multi-level sensors, evolutionary optimization, voting algorithms, and much more. So I'm sure you can imagine that this AI engine analyzes hundreds, if not thousands, of factors basically for us to determine two key factors. Firstly, which factors are relevant for prognosis of the patient's health state. And secondly, which factors are relevant for the optimization of medication. And as mentioned, importantly, the treatment decisions are always guided by current heart failure clinical guidelines, which are enhanced by AI deep learning. Also, the integration of serious gaming motivates regular use of the application and provides additional diagnostic information. On a more practical level, smart coaching of DrMe educates, upskills, and empowers patients to optimize effective heart failure self-treatment in consideration of their disease complexity. Also of much importance in the deployment of such cutting-edge technologies, we have integrated robust governance to provide transparency, abide by ethical principles, ensure high-level data protection and security, and of course, to minimize risk. In addition to the AI platform, co-production was a key aspect in the development of DrMe. So we did a sub-study, and the aim of that was to identify the key determinants influencing patients with heart failure and caregivers' acceptance of a heart failure avatar doctor. So what we did was we engaged 49 patients and 33 caregivers across four of the countries, Germany, Ireland, the Netherlands, and the UK, to identify key determinants influencing patient and carer acceptance of an avatar decision-making support system, our DrMe. So what we found was that overall, participants were open and receptive to using a digital solution. There were four main categories that emerged from the data: needs and expectations, preferences regarding the care process, perceived risk, and trust. So just to give you a little bit more information, participants expressed clear wishes and expectations regarding a doctor at home, especially the need for reassurance and 24/7 support in the management of heart failure. They were receptive to changes to current heart care processes. However, trust was identified as an important basis for acceptance and use. So what the identification of barriers and facilitators translated to was assistance in optimizing the development of DrMe with regard to the treatment of heart failure through the use of an avatar. As our product is yet to be released, I am unable to provide an example of the DrMe avatar. However, what I can do is show you a demonstration of the prequel to DrMe, which is an avatar called Molly that is similar to our current, more advanced version. And even though this video is only 2 minutes long, it will give you a clearer picture of our heart failure patient digital health support. And as you will see in this video, it not only offers support for the management of their heart failure, but also provides patients with a sense of psychological support through their engagement with the avatar, noting that depression and anxiety are highly prevalent in heart failure patients.
Our app can be a part of their lives every day. So our avatar, Molly, she can check in with the patient every single morning, more than once a day if that's needed. She can ask the patients how they're doing. She can collect really important information such as their weight or their blood pressure, glucose levels, ask them relevant questions to whatever condition they might have. And all this information can be funneled back to the clinician seamlessly, so the clinician can just be alerted to which patients are actually possibly having an issue that day.
Your weight is 190.9 pounds. You did not gain any weight. That's good. Now let's take your blood pressure. Please make sure the cuff is on by pressing the orange button on the side of the
Because
cuff.
we have this avatar that talks to you and you can talk back to, it makes people way more engaged because patients have told me it's comforting to have her. It's like someone's holding my hand and they would rather talk to her than just use an app on their phone. And because of that engagement level, they're more likely to do these types of things to keep themselves healthier.
Pressure is 149/94. Your pulse is 81 beats per minute. Your blood pressure is a bit high today. We will keep monitoring that. Now that we are done taking your vitals, I want to ask you more about how you are feeling. If you are experiencing shortness of breath, is it worse than normal? Anything else you want to tell me?
No.
Because of your results this morning, you need to check in with the nurse to see if there are any adjustments you need to make to your clinical routine. It's outside of regular office hours, but I can still connect you with someone. Would you like me to do so? All right. A nurse will give you a call back on the next business day to see how you are doing. Thanks for your time, and I will talk to you tomorrow. Goodbye.
So the current status of DrMe is the 5 countries have just all embarked on a feasibility trial, the aim of which was to test the usability of the avatar in terms of its feasibility, which meant its acceptability, compliance, and adherence. So we've just had ethics approval from across each of the sites individually. This trial will comprise 600 patients in total across the 5 countries. It will be run across 26 weeks with data collation at baseline 12 weeks and at the 26th week. We have many outcomes. However, the key outcomes would be ease of use, satisfaction, motivation, working whether or not, determining whether it's working as intended, self-management, quality of life, morbidity, and healthcare service use. So I'll certainly look forward to reporting the results of the trial at next year's AI Festival. For now, in summary, what DrMe has been designed to do is offer a solution to current healthcare challenges, such as overloaded systems, limited healthcare resources, high levels of clinician burnout, increased patient and clinician mental health issues, and increased waiting times. This can be seen on the diagram here. And as DrMe participates in an increasing number of medical tasks traditionally performed by healthcare practitioners that fundamentally go beyond human cognition, such as processing big data and specific diagnosis, to routine tasks that can help reduce the workload of cardiologists and heart failure nurses. DrMe's solutions include a number of things as listed here, such as patient-centered care being available 24/7, multi-level diagnostics enabling predictive care, improved decision-making, accuracy, and efficiency. And through empowering patients, it promotes independence. And also, it's important to make a note of and cover the long-term outcomes that we envision from DrMe, which are, well, firstly, to transform heart failure healthcare from profession-driven to patient-driven care, with the patient being supported up to the highest level of care. And secondly, optimal self-care will reflect on costs resulting from reduced contacts with professionals and less hospitalizations. So the last thing I'll cover is what's next for the Passion HF Consortium. Well, we've just submitted a second bid to Interreg to adapt DrMe to the most complex of heart failure cases, which is older patients due to their frailty and multimorbidities, which also will add several new dimensions of complexity. This will be a second trial that will target older heart failure patients across rural Suffolk, which would aim to achieve 3 outcomes. Reducing health inequalities, this being digital and social isolation, empowering patients to become better self-managers, and improving health outcomes and quality of life. Thank you.
Chantal, thank you so much for what was just a fascinating talk. We at BT are kind of really interested in healthcare and what innovations we can bring to bear in terms of improving health services, just as you were sort of saying in your talk there. I'd be fascinated to have a conversation about how we might work together on bringing some of your creations into the trials that we are running. But one of the things that I was wondering, would be very grateful if you could bring a bit more colour to, is how you take the physical readings in terms of what's presenting in terms of blood pressure and monitoring and all the rest of it, versus what the patient is actually saying, and how do you take those two pieces of data and kind of make decisions on the back of that? Especially if they conflict, I guess, as well. If the patient is saying they're feeling fine, but the readings are saying something different.
Yeah. Well, in terms of the heart failure patient, it is very complex. But at the end of the day, we do have to take the readings first. So there are a number of signs and symptoms that are going on. We have to look at their blood pressure. We have to look at swelling, but they have to report back to us also. They have to watch their fluid intake, their salt intake. And as you've said, what about the patient compared to all of the clinical and vital signs? Well, yes, we have to take the vital signs on board first. But another interesting point here is the psychological association between heart disease and, say, depression and anxiety. And they're often through the roof. And they can also, it's a bidirectional relationship, so they can also affect the vital signs. They can increase stress, increases blood pressure. And so it's almost like a combination of things, an algorithm that goes on in our own heads of putting all of this information together, of the exact advice that we're going to give them. And in terms of artificial intelligence, the thing is, when the patient presents to a clinician, they're in a way limited to the amount of information that they have on that patient, whereas DrMe has so much more information. It has information from many, many years of treating that patient. It has information from medical records. It has information from guidelines. It has all the algorithms that we've put together as clinicians into the platform. And it's taking into consideration all of those things.
Okay.
So, yeah, it's a very interesting point that you raised.
Perfect. Fantastic.
And Chantal, you talk about the next phase of trials starting to look at slightly more complicated use cases. But is there a limit to the complexity of the treatment that DrMe advises and gives out?
Yeah. Well, put most simply, heart failure is what it is a damaged heart. And what that means is it's more difficult for the heart to pump around the blood, nutrients, oxygen throughout the body. And so the outcomes for heart failure patients aren't good. And so over time, heart failure patients do tend to deteriorate. And so in addition to not only what they're presenting on the day, but over time with their worsening heart failure, there will be a ceiling where DrMe has to refer. And that's all built into the platform. So there are specific ceilings for when DrMe will say to the patient, thank you very much, we will now refer you. And that can be done immediately to the emergency department or to the heart failure nurse or to the clinician.
Okay.
So the actuation on the back of that information is kind of really critical, essentially. I'm interested, obviously, heart failure can span all generations. But something that I'm interested in, and we are considering as part of some of the trials that we're doing, is, for example, I have a 91-year-old mother who dislikes any interaction with technology whatsoever. I think I've just about managed to get her to interact with a Facebook portal so that I can video call her. Have you done any research or have you had any thinking about that as a barrier to uptake in terms of your DrMe solution?
Yeah, absolutely. We're working closely. Well, at the University of Suffolk, we have Professor Nick Cordwell, who's already looked and done investigations into AI and looking at technology in older populations. And there has been a little bit of research out there. And what they're finding is that those initial barriers that seem to be there are there until we actually get in front of the patient and train them. And it's interesting because it's often with family. They don't want to admit to their family or be advised by family members of how to adapt this technology. They actually adapt better and learn better if it's a stranger educating them or a professional.
Yeah, it's a bit like teaching your son to drive. Doesn't work.
Personal experience.
Yes.
I guess another question, Chantal, is more about the results of what you're finding and how DrMe, again, about that treatment that's advised. Because a lot of the things that we've been talking about is how AI can be biased, or you might get some erroneous results. Never are the stakes higher than in the topic you're talking about. Does that cause a barrier to some of the work you're doing?
No, they are there, and we need to be aware of them. But at the same time, my background is a psychologist, so I don't know the exact technologies that are going on. But I do know that they're working through those biases. And if there's been a couple of studies done that compare the biases that have come across through, say, machine learning, compared to the biases that are already in place in the role of a clinician, and at least we can say, luckily, through the AI, the biases are less.
Yeah, that makes sense.
I think probably last question from us, I think, Darren. Chantal, something that we were discussing when we were listening to your keynote was the fact that actually you're specifically looking at the conditions and the readings with respect to heart failure. But is there, it seems obvious almost that there's an opportunity to extrapolate that and identify that, there may be other conditions in play for a patient. Do you anticipate that will be the extension of this kind of capability? And are there any barriers in terms of that as a scenario? Or do you have to keep it very specific to a condition?
Yes, you do absolutely have to keep it specific to each condition. But at the same time, what our consortium has always been working towards, and what we've been saying in a few of the publications that we've had out, is that once we've trialled this, and if it works out, this is our blueprint to extend across many other long-term conditions.
Okay, thank you very much.
Chantal, thank you so much again. Really appreciate your time. It was a brilliant talk. Thank you.